A mental illness is a disease like many other diseases. 2 out of every 5 people may experience a mental disorder in their lifetime. For 1 out of 17, the illness will be serious and disabling. Today, however, modern treatment, medicine, and therapy can produce excellent outcomes, especially with early diagnosis and intervention. So why do so many people let fear, shame, and stigma prevent them from seeking the care that will help them most? Queens Public Television will explore these issues and more in this series, Understanding Mental Illness. For people with mental illness, advances in treatment, medications, and therapies have drastically reduced the need for long hospital stays in psychiatric centers such as Creedmoor. But who determines when a patient is ready to resume life in the community? And what supports are available to sustain them when they return? Erin remembers arriving here under different circumstances in 1998. She had failed to respond to treatment at Zucker Hillside Hospital.
They brought me here because basically I wasn't doing what I was supposed to do in the other hospital. I was fighting. I wasn't eating. I wasn't taking medication. Wasn't attending the groups. Basically anything that they told me to do, I was doing the opposite. It was a horrible experience. It was, I was brought in an ambulance on a stretcher, restrained, and it was like coming in and knowing you have to go, it's a lot different from the other hospitals I've been in where you don't go through a double door security. They have to buzz you in and you're wheeled in one door and then you're wheeled in another door. And it just feels like that's it. You're locked in there. There's no way you're getting out. That's what it felt like.
We have a level system at Creedmoor of privileges. So when a person first comes, they don't have privileges because we have to evaluate them. And oftentimes they're not in a state where they're able to be more independent. But as they start to do better and they start to stabilize, they can engage in different type of activities that are less structured on the ward. So for example, we take groups from the ward into this building, for example, to art therapy or music therapy, or to the computer workshop upstairs. That's a group that's escorted by someone from the unit. So that we call level 1A. They can go out of the ward with a staff member. We feel they're well enough to do that, and they can start to go to some of those groups. When we feel they're at a place where they could go within the building and they're responsible enough and independent enough to do that, then they can start to go to some of these programs on their own. First I was bipolar. I'm trying to remember. There was a lot. I mean, borderline. I think it came down to towards the end was more of depression, and then I also had the eating, some addiction, so it kind of all rolled into one there.
My job is to remind the patient when they come into the hospital, this is a hospital. It's not a home. It's not a place to stay. It's just like if we go into the hospital with appendicitis, we get better, we go home. And hopefully someone will ask us what we'll need when we go home and put that package together. And that's really my job, to make sure that package is together, that the treatment team is talking to the patient, that we have everything they need when they go back to their home.
There are a number of challenges that await them. One challenge is learning to live independently, learning to negotiate a number of systems which are difficult for people without mental illness, negotiating medical care, negotiating benefits, negotiating just reaching your appointment and taking your medicine on time. These are challenges they have to face every day.
A typical team is composed of the psychiatrist, the clinical social worker, a psychiatric nurse, a rehabilitation person, a peer, and everybody talks about, because everybody brings something else to the table. Rehabilitation is more strengthening day-to-day tasks with the client, teaching them and talking about washing and living their day-to-day tasks. The clinical social worker is really making sure the family issues, their socialization is in place, and of course the psychiatrist does the medication. So it's a team effort. You have to look at everything with the patient if you want the patient to get better. And the patient is a big part of the team, because if they're not buying into it, it's not going to work.
I think I thought more at first I was just being, like I said, defiant, like a rebel. Like I just didn't want to do what people told me. I want to be different. I want, But I think later on, as I was here longer, I did start to realize that maybe I just, had something. There was an illness. I couldn't control it, and I had to kind of give in, so to speak, I guess, and let the doctors. They knew what they were talking about.
We're not just talking about medication. When the psychiatrist is there, the psychiatrist may say, I think this person needs psychological testing. We have a question about their cognitive function. So they turn to the psychologist for that. We have daily meetings in the morning, every morning called rounds, where we sit down and take a book that's called a shift-to-shift book. Every shift writes in this book. And anything that's happened during the day, so we can communicate what's gone on for a 24-hour period. Anything that needs to be addressed immediately, we discuss it right then and there in that meeting. Anything that we can wait on, that we have on our ward, we have a longer meeting later on in the week, we would discuss it in more depth. And we still might discuss it in more depth, but if it needs to be done right away, obviously we take care of it right away. But we're all sitting together in that meeting, so we're communicating with each other.
The decision when the patient is ready to leave the hospital is really determined by the treatment team. The progress they make, if the medication is working, if they have reached their baseline psychiatrically, that everything is in place, and that we start that process. We really believe to empower someone is to provide them with knowledge, and we really start providing that knowledge as soon as the patient is ready to discuss it. We have all type of programs here that provides them with education to what's out there for them and what they will need, because some people, as we all unfortunately are getting older, families are aging out and they're no longer able to go back home and live with their families.
Some clients return to their homes, and we will provide services to those. I think that type of service is very beneficial for families that are caring for mentally ill patients when they have an ICM come in and assist in the process of readjusting into the community.
We have to start looking at a different type of environment, and those are some of the big challenges we're having right now.
The challenges of integrating care, I think that is one of the challenges that we face all the time, because we have the patient has a psychiatrist, patient has an internist, patient has to go to a podiatrist. So like all of us have 2-3 doctors, that is these modern times. So to integrate care so that everyone talks to each other, and that's a challenge.
This is one thing that's really wonderful about this hospital, and I think really the Office of Mental Health system, which is different than the other systems and private hospitals. They really insist that we have a plan when the person's discharged, that they're not just going out and doing nothing all day, that there's treatment set up, that there's some kind of program set up for them. It could be that they're going to school, it could be that they have a job that they're going to, or it could be going to a program, but they're not supposed to just go and sit home all day. It's really important.
When the team and Erin were satisfied with her progress and plan, she was released. For her, the journey had been a gradual process.
There wasn't like a single thing that happened that made me, I think, realize that there was a hope, I think it was a combination of things. There was certain staff that stand out as being really, really caring, being, kind of going above and beyond. And those kind of staff that didn't look at you as a crazy person, but that just looked at you as a human being that had just been through some stuff and struggled and could go on, to be like, and, I say in recovery, I never say recovered, but that's just a whole, what I've been taught, because I'm always going to have things, so I'm always in recovery, but staff that kind of believe that you can, this isn't your last stop. You don't have to end it here. Like, you can go out and do things, and that was a big part of it, like having those people in my life.
I think the key is when they come out of the inpatient and they make a connection to a clinic, that the the beginning part of that has to be negotiated, and they have a good treatment team that they start trusting and they start working with. And once they have that in place, I think the prognosis is very good.
Transitional Services of New York offers short-term treatment and ongoing support at their clinic in Jamaica, Queens.
Once a person who has a psychiatric diagnosis comes out of a hospital and they need obviously at that time a tremendous amount of support, they're ready to come into the community. And that's where we fit in, because we have all the services necessary to help them transition from a point in their life where they need a lot of support to a point in their life where they need less support. And historically, that's what our agency was founded on. People were coming out of many years in the hospital. Back in the 70s, people were in the hospital for 30, 40 years. And with the advent of medication and people could become more stable, they could progress to live out in the community.
It's very important that we not only treat the patient biologically, but treat every aspect of the patient. And one of the things we're able to do at TSI is to assist the patient with case management, to help to link them to other services that they need, whether it be getting disability, food stamps, going to DSS, renewing their Medicaid, and housing.
Some of them are different levels of functioning. We have what's called a supervised level, where it's usually a 24-bed residence, which will have round-the-clock staffing. Most of them provide meals to the clients. They have to take care of their own room. They have to have the skills to do their own laundry. If they don't have the skills now, they'll be taught to them. Then we have apartment treatments, that patients can actually go live with someone else in an apartment, have their own room, and share communal areas to be able to do that. And then there are individual apartments that patients can also live in. There's also what's called adult homes. These are older hotels that have been converted into a group home situation where if somebody don't want to cook, somebody don't want to do their own laundry, they'll have someone come in once a week to do their laundry. They'll clean their rooms for them. They'll prepare 3 meals a day for them. So they have different options if they choose, and the treatment team agrees with them, and they can move to these different placement options.
People are referred from any type of psychiatric professional to our services. They don't necessarily need to be referred from a hospital. The majority of people, though, in our residential programs are referred from hospitalization to very often the first setting, but that doesn't have to be. If they have some community experience, they can move out into an apartment treatment program, or they may have the skills that they can focus in on. They may know how to cook and they may know how to clean. They may not need that type of training. So it's a very fluid type of model, but we're always there to provide the support that they need. And they can be referred from a community psychiatrist. They can be referred from a substance abuse facility because they now have or they may have had a mental illness. So, and that became more clear as they got off drugs or alcohol.
Most patients nowadays with mental health problems also have a co-occurring substance use disorder. Similarly, people who present for treatment for substance abuse problems, approximately 50% of those patients have some other psychiatric illness in addition to substance abuse. So when we talk about substance abuse and mental illness, we're really talking about a large percentage of patients who have both, sometimes 3 or 4 different disorders simultaneously.
As the state discharges the patients and they come into the community, these patients need a stable place to live. They do not need to be homeless out in the community. And the problem, of course, when people are homeless is that sometimes they commit petty crimes and they end up put in jail. Rikers Island houses the largest amount of psychiatric patients at this point in New York State. It is no longer the state hospitals. As they've been released and adequate housing has not been provided, the patients, unfortunately, are now being housed in jails. And of course, that is the worst place for a person who's mentally ill to be.
We do have a responsibility to the patients, we have a responsibility to the families, and we have a responsibility to the community, because we don't put people out into the community before they're ready. I think a lot of the stories that you hear about people who have a mental illness, who that have done something bad in the world, are the people that are not receiving treatment. That's what the statistics show. The people that we're servicing, we do an amazing job of treating people to stay out in the community, to get the services that they need.
But clients can become uneasy as they prepare to resume life outside the hospital.
It's not the most comfortable thing in the world to hear voices or to see things or to feel frightened all the time, and that people are out to get you. I mean, those are the symptoms, but that doesn't mean that the person is not uncomfortable, and they are uncomfortable, and they know they're getting the support in a structured environment. And then to move on, you feel shaky. You don't feel, what happens if I start to experience it again? Who am I supposed to call? What am I supposed to do? And that's where we come in at Transitional Services. We're going to provide that support for them to go ahead and so that they don't feel so shaky.
I remember, like, right before I was leaving, like, how, like, I actually started, not to, like, I don't want to say, like, love it here, but I think I started realizing that this was the place that kind of gave me, you know, the strength to kind of go out there and live the rest of my life. You know, like, I think if I had continued on the way I was continuing on, I don't think I'd be where I am today.
So they move into a supervised setting, they move into a place where they receive a lot of support, and as they learn the skills necessary to move out into the community, and skills that you and I sometimes may take for granted, like cooking and cleaning and budgeting and all the things that we may have learned as teenagers that we had the opportunity to practice, they didn't have the opportunity to practice because they had their illness. The illness onset was between the ages of 18 and 24. So they come in and they go ahead and they learn those skills and they practice those skills. They're taking their medication and they go out to then hopefully the next step, which might be an apartment type of treatment.
Transitional Services provides many housing opportunities, but not without issues.
I can't say that there's a lot of acceptance for those homes and the apartments. I think people don't realize that there's somebody living next door to them that has a mental illness. I think if you look back at the statistics of 1 in 4 people are suffering from a mental illness. If you live in an apartment building in Queens, you probably have somebody in your building that has a psychiatric diagnosis. That doesn't mean that they can't work, and it doesn't mean that they can't function, and it doesn't mean that they can't raise their children, and it doesn't mean that they're stupid. And those are the things that we try to get people to really understand. It's been really fascinating as we've developed our supported housing program that the landlords are coming to us. Because think about it. 1, a landlord is guaranteed the rent, which is really a big thing. And 2, if you're a landlord and you have a problem with a tenant, you no longer have to deal with that tenant necessarily. You can call somebody and say, I'm having a problem with John. Can you please send somebody out to, they can't do that with a quote unquote normal tenant.
TSI's record of success with their housing units can help pave the way.
I know our reputation is excellent, and that's why the landlords are calling us, because we do provide the services and we do stick to our commitment of being available to help the tenant make it a successful landlord-tenant relationship. And we have over about 300 people placed in that supported apartment program at this point, and we're not having a problem getting apartments.
For Transitional Services, the recent dedication of the Hazel House residence on the Creedmoor grounds opened new doors for clients in transition.
In our new facility, the people that are living there are going to get the opportunity to cook for themselves, clean for themselves, and adjust to being back out into the community. A lot of the people came from the hospital, or they came from much more supervised settings. So this is another step for them. That's what's unique about it. It's just another step in the process of getting back out into your own apartment in the community, integrated in with the regular quote-unquote normal population. It's not that normalizing living with 52 other psychiatric clients, but it's a step. Years ago, many people were frightened actually of taking that next step and living out in the community. Not so much anymore. They actually know that they've been successful at points in their life. Their friends have been successful in living out in the community, and just like I might live out in the community and taking care of my family and taking care of everything that I need to do on a daily basis. They want that same opportunity. What they don't necessarily want is to have to live with somebody in a small, tight quarter those small tight quarters. We're adults. They want to live on they want to have a bedroom by themselves. Sometimes they want to share an apartment though, because it can get very lonely. So that our SRO has 2 bedrooms. So people can have their own bedroom space, but then come out and socialize a little bit. And we'll have socialization activities for people, movie nights, things that they can go ahead and take advantage of.
Legislation known as Kendra's Law provides assisted outpatient treatment, or AOT, for some patients who are judged to be at risk if left on their own.
We also have what's called AOT, where patients are mandated for treatment. We have patients who are actually mandated by the courts to follow through with their treatment. It's really people who have not been able to comply and have a history of getting into trouble, either violence with the law for whatever reasons. So we will put a treatment plan together. We will present it to the court. We will have all people involved with this patient sign off on this, and they've agreed to this. And patient understands if they are not compliant to all these conditions, they can be picked up for evaluation at any time.
Non-compliance for our patients is caused by many different reasons. The major factor, of course, is the side effects that our patients can manifest on these medications. Fatigue, weight gain, medical problems such as diabetes, high cholesterol. These cognitive side effects are also some of the side effects that patients can have, and then this makes patients sometimes not want to take the medications. The other issue also is that when patients feel better, they think that they no longer need the medication, and then they start to miss doses, or they think they don't need it anymore. And unfortunately, what happens over time is that the blood level decreases, and the symptoms can come back and cause the patient to decompensate.
Medication is key. I think most people in the community don't want to take medication if they feel better. Many people go ahead and take an antibiotic until they feel better. I mean, not everybody finishes the script. And the same thing happens within mental illness. There's some evidence that if you take the medication on a long-term basis, I think that's probably the better example. If you take it on a long-term basis, you can make progress. And getting people to understand that and practice that skill is extremely important.
As patients near their exit date, yet another program provides support and encouragement.
In my department, I have what's called a Bridger program, where we will start working with patients for at least 3 months prior to their discharge. And then we will meet with them 2 or 3 times a week. And we take them to socialization, we do travel training, we take them into the community and really take them to different places and let them see what's available and have them make their choices of where they want to be.
Sometimes the best resource is someone who has gone through the same experiences you have. Peer counseling is a recent movement which employs past patients to help present ones reach their goals. The counselors have experienced much of what the patients are living through.
I became a peer counselor because of having experience with having somebody that was a peer counselor to me, and seeing like the benefits of having another person that's been where you've been. Like, the stories aren't the same. Everybody's here or there or, for their own reason, but they can identify with the feelings. And because I've had such a positive experience with it, I wanted to help people. I wanted to be able to share my story and be able to help them see, like, just because you've been diagnosed with this or just because you've been in the hospital does not mean that you can't, go on and live your life. So I've definitely, just from positive experience, kind of pushed me in that direction.
A major point about TSI is we're going to continue to exist. We're going to continue to grow. There's a lot of people that need services, and I really focus in on providing the quality of care that allows us to grow, to be recognized throughout the state of New York.
Erin is wonderful. She's wonderful. Doing the things that I've always wanted to do in my life. Like I said, I'm going back to school, and my goal is to become a psych nurse, something I've always wanted to do. And I'm just living my life. I'm living my life. I'm sing with a band, which is another dream of mine, to sing. And just good. I have bad days just like every other normal person, so, but my bad days don't get so bad. And I just know, like, tomorrow's another day. Like little Orphan Annie said, the sun's gonna come out. Maybe not today, but it's always there, and that's what I just do. And I'm doing absolutely wonderful. I love my life.
I'm here because I really love working with the patients, and I love seeing them get better. Again, my philosophy is this is a hospital. It's not a place that people stay the rest of their lives. So we want to bring everything together, the family members, the providers, and try to make it a successful placement as possible. We do acknowledge that some may have to come back, but that doesn't mean they have to stay the second time either.
Not at all. I do not worry at all about my illness returning. And I think even if it did, even if I got really, really, really depressed, I've come way too far, and I know way too many things to let it go where it did.
Erin has remained well and is now working as a counselor at Hazel House. And in June 2012, she celebrated her wedding.
My husband's name is Kevin, and he's amazing. He knows my past. He doesn't judge me. He accepts me for who I am, and he encourages me, supports me, like, very much. I'm going back to school, and I keep thinking, like, I can't do it. And he tells me all the time, yeah, you can do this, you can do this. He just, it's like always there for me.
Don't fear mental illness. I mean, the person sitting next to you on the subway might have a psychiatric diagnosis. The person that you're talking to, your family member. It's time to really start opening up about it. I mean, we hear about it in the movie stars, and there's almost a glamour to it. So-and-so is mentally ill this week. It's nice that they come out and they talk about it, but the advocacy needs to be there to get it to the rest of the population. The services need to be there for the rest of the population to decrease the stigma that exists in the world regarding mental illness. It doesn't need to be there. If we do the education and we show people what a mentally ill person is, what they experience, and that they can make progress, we'd all be a lot better off.
In November 2013, Erin started work back in Building 40 as a peer specialist.